Hello, and welcome to Informed in 30, National Brain Tumor Society's education initiative committed to providing patients with a brain tumor and their caregivers with key information about cutting edge advancements in brain tumor research and treatment. Our topic today is managing quality of life care in pediatric brain tumors. My name is Rachel Kittleson, and I am the Director of Community Relations at the National Brain Tumor Society and a patient advocate on the NBTS Personalized Support and Navigation team. Joining us today are Dr. Joanne Porter, Professor of Pediatrics Division of Pediatric Hematology, Oncology at the Melodies Center for Childhood Cancer and Blood Disorders, and Director of the Journeys Pediatric Palliative Program at Albany Medical Center, and Dr. Lauren Weintraub, Associate Professor of Pediatrics and Director of Pediatric Neuro-Oncology at the Melodies Center for Pediatric Cancer and Blood Disorders at Albany Medical Center. Thank you both for joining us today.
Thanks, Rachel. I'm pleased to be part of this educational program, and I look forward to helping our brain tumor community learn more about this important topic.
Thanks, Rachel. I agree with Dr. Porter. It's exciting to be a part of educating our families about quality of life care and what it means for the treatment of pediatric brain tumors.
Thank you both. Quality of life care is such an important component of treating patients with pediatric brain tumors and their families, and yet it can be misunderstood. While the term palliative care is often equated with hospice and end-of-life care, hospice is just one setting where palliative care is provided. In fact, incorporating palliative care, sometimes also referred to as supportive or comfort care, from the time of diagnosis can help patients and their families with medical symptoms and psychosocial issues. We are so pleased to have both Dr. Porter and Dr. Weintraub here with us today to help our community better understand what quality of life care is, terminology surrounding quality of life care, who is part of palliative care teams, and what families should ask about this type of care. And with that, Dr. Weintraub, I would love to turn it over to you.
Again, thank you, Rachel, for including me in this important discussion. As mentioned, I'm the director of the Pediatric Brain Tumor Program at Albany Medical Center. I'm fortunate to work with experts involved in treating all aspects of pediatric brain tumor patients, including a specialized team focused on quality of life. So what I'd like to do is give a brief introduction to pediatric brain tumors and highlight why quality of life is so important, and then turn it over to Dr. Porter to elaborate on how her team is able to hone in on this type of care. As I'm sure most parents are aware, pediatric brain tumors account for a large portion of pediatric cancer, with approximately 3,000 new diagnoses each year. While the majority of children are able to be cured, brain tumors remain the leading cause of cancer-related death in children. The treatment of pediatric brain tumors is multifactorial, most commonly involving surgery, radiation therapy, chemotherapy, or a combination of all. Many brain tumors can be observed, although this does not mean the patient does not require other forms of treatment. And in fact, the pediatric brain tumor patient can require treatment that is far more comprehensive than just radiation and chemotherapy. It can involve treatment of the child by a team of experts, not only trained in treating the tumor, but also all the associated issues, both physical and mental. The pediatric brain tumor journey can be quite long and involved, and it begins at the time the child experiences symptoms and can continue for months or even years, involving multiple treatments, follow-up visits, imaging, often repeat surgical procedures, hospitalizations, clinic visits. And when you think about all of the places a brain tumor can occur, it becomes obvious that these children and families are not just dealing with cancer. They're dealing with something that can affect the child's quality of life just by virtue of where the tumor is located. And so for this reason, brain tumors are often said to have a very high symptom burden. And it is for this reason that it is imperative that we focus on care that maximizes the quality of life of a pediatric brain tumor patient. The term quality of life care has become synonymous with palliative care. Often people think of palliative care as end of life care, and while this may be a part of palliative or quality of life care, it is not synonymous. And hospice care is a separate entity that can be facilitated by palliative and quality of life care providers, but is certainly separate from quality of life. And in fact, independent of prognosis, there's evidence that early integration of quality of life or palliative care services leads to improved quality of life and symptom management in these patients. So, what exactly is quality of life care? It's an approach that focuses on improving the quality of life of a patient facing a life-threatening disease. And it can be accomplished by any of the patient's providers, prioritizing symptom management and addressing other associated physical and psychological issues that arise. Such care is concurrent with curative treatment, does not necessarily replace this treatment, and typically is provided by the child's primary neuro-oncologist, as well as a team of other specialists that may include palliative care physicians, social workers, and psychologists. To be even more specific, providers can address symptom management using specific medications like steroids, anti-nausea treatments, as well as pain medication. And palliative care team members may help with care coordination and spiritual support, while other providers provide psychiatric support and sometimes end-of-life care. So why is this so important in pediatrics? So childhood is a time of emotional and cognitive development. We can't simply treat a tumor and ignore the child during this time. Providers need to focus on reducing the stress of treatment and address the entire needs of the family. So going back to our timeline of the pediatric brain tumor journey, we have to remember that the child is still experiencing normal childhood milestones throughout their treatment. And because this journey looks different at various time points, the quality of life care may look different as well. In the beginning, there may be a focus on coping strategies, and the providers may need to spend more time with the patient and family to help them better understand the diagnosis. As treatment starts, quality of life care may shift to a focus on symptom management. And then certainly during the survivorship phase, which is the phase of treatment after the completion of the traditional therapy, there may be a focus on the emotional and physical toll of the prior treatment. The long-term effects of treating a pediatric brain tumor can be significant, and so there is a clear need to continue quality of life care after treatment ends. And this may be even more than during the treatment phase. We know that when there is more of a focus on quality of life during the treatment phase, patients actually do better during the survivorship phase. And of course, we know that there's far too often a need to shift to end-of-life care. But again, we know that even when this is the case, families, the parents, the siblings tend to cope better following the loss of a child if the medical team had focused on quality of life while the patient was being treated. And so with that, I will turn this over to Dr. Porter.
Thanks so much, Lauren, for setting the stage for this special population. For our audience, the last 5 years, Dr. Weintraub and I have been working together to offer comprehensive services to children and their families who are undergoing treatment for brain tumors. As part of the global initiative, she and I feel strongly that the palliative care supports, otherwise, as she mentioned, represent quality of life efforts, are critically needed for this special population. We hope that we can convince you too as we continue this dialogue. Let's start with the basics. This is a definition of palliative care that has evolved over the last 20 years. Palliative care is one of the fastest growing medical subspecialties in medicine today. 2 key points for the listeners to realize is number one, that medical professionals and the lay public continue to confuse palliative care with hospice care, leading to delays in referrals and initiation of appropriate supportive treatment. And number two, many professionals do not understand that palliative care is for everyone, regardless of their diagnosis, stage, and treatment plan. For the last 25 years, leaders in the field of palliative care have worked tirelessly to educate and inform the public, the medical community, and the state legislatures across the country to raise awareness and acceptance of this growing medical subspecialty. Today, most large hospitals with more than 300 beds have a palliative care team embedded. Additionally, most children's hospitals have pediatric palliative care specialty teams. Our program at the Duker Children's Hospital in Albany has been operating for over 12 years now. This definition, as represented on this slide, is very broad and encompasses the main focus of palliative care: to offer the patient and family an extra layer of support. I can think of no patient population more deserving for this type of intervention than our pediatric brain tumor population. So this cartoon outlines the interface of palliative care in the yellow triangle, disease-directed care in the red triangle, and end-of-life care over to the right in varying shades of gold. You can see, Rachel, that the current thinking is that palliative care can be and should be offered to anyone with a serious illness during their illness and disease-directed therapy. As disease-directed therapy fails for some patients, then palliative care support expands and becomes even more important and can lead to hospice care and end-of-life supports. In the pediatric world, most palliative care teams work hand in hand with the many medical specialists to deliver this type of care. Equally, we work very closely in collaboration with the hospice teams to help offer pediatric expertise for end-of-life care. Palliative care is delivered by a wide range of specialists, often referred to as an interdisciplinary team. I've underlined the core group of needed specialists, but we include many other professionals from different subspecialties. The goal is to offer the child and family whatever it is they need to help support them through their medical journey. We work with obviously nurses and social workers, case management, but often we may need to collaborate with mental health counselors, psychologists, or psychiatrists. Sometimes many of these patients need PT, OT, speech therapy, different adjunctive therapists to try and help them achieve their goals. We've often consulted legal experts if that's necessary, and even involved the ethics team as indicated. Our goal is to help the family and the child throughout the treatment process to enable them to achieve their goals. As Dr. Weintraub mentioned, the treatment process for children with brain tumors is multifaceted. The needs for each child will change as they navigate each phase. Equally, the emotional and psychological needs will evolve during the course of treatment and recovery. So too will our involvement and the interventions that we offer. In particular, the child with a brain tumor may have physical deficits related to the tumor itself and/or the surgery. They undoubtedly have emotional fallout from the illness and perhaps treatment. So a palliative care approach is integral to the medical treatment planning to help support the child at every step of the way, adjusting our interventions as needed as the child evolves during his treatment course. Lastly, our approach is family-centered, meaning that we support the whole family, including the siblings, the school team, and the local community providers with educational outreach, potentially support for the school staff as a child returns to the school environment, And we counsel the therapists working with the child as they recover and perhaps begin to make new gains. So you can see, Rachel, that it takes a village to deliver the level of comprehensive care that we feel is needed. Some of the different interventions are listed here on this slide. So when we discuss an extra layer of support, what does that really mean? Always we tailor our activities to what the child needs based on their medical condition. Addressing simple symptoms probably leads the list, especially in the beginning of treatment. But as time goes on, we may delve into other areas. Goals of care is a term used to address what the family understands and perhaps what the patient understands about prognosis, recognizing that prognosis might change as the journey progresses and thus will need to be readdressed perhaps more than one time. Coordination of care is about making sure that all of the providers are on the same page. And we try very hard to involve the many subspecialists that are involved in the care of the child and ensure that there's adequate communication to all. Our team does a lot of education and outreach to the child's greater community supports. That includes the pediatricians, the school teachers and staff members, possibly the sports teams, and even church groups. And of course, we're actively involved in counseling and bereavement when indicated. Palliative care delivery ideally traverses the care continuum, meaning that we help support the child and family wherever they are. To accomplish that can be pretty daunting, but it's worthwhile to ensure that the child and family has supports as they integrate back into the community. Most palliative care teams are meeting families in the hospital at diagnosis. Our palliative care team, the Journeys team, follows children in the outpatient clinics as well as in the hospital to monitor their progress and continue to support them as care evolves. We partner with the Neuro-Oncology team to deliver comprehensive and compassionate care to the whole family throughout their medical journey. Some of our fragile kids require home care visits for ongoing support, and that's offered as indicated based on the child's medical condition. I was asked to address some of the issues about finding a palliative care team. You can imagine that a child diagnosed with a brain tumor is likely to be at a specialty center, likely at a children's hospital, and likely being managed by a pediatric neuro-oncology team. Almost all children's hospitals have pediatric palliative care teams, but they may be at different levels of staffing, meaning that they may not have a full complement of staff that I've presented here. As palliative care becomes more widely accepted, you'll see that many of these teams are growing in popularity and in staffing to try and help provide all elements of quality of life care for these patients. As I mentioned in the introduction, one of the biggest challenges in the palliative care world is that not all doctors understand that palliative care is for everyone, regardless of the diagnosis, the stage of illness, and the medical treatment. The tide is slowly shifting with more and more acceptance. One suggestion for families would be to request a palliative care consult for an extra layer of support and quality initiatives. There are several resources online that can also help you find out about palliative care in general, and that might also help you as you navigate within your hospital system. This is a series of resources that are available online. The Center to Advance Palliative Care is based in Manhattan and has become the national advocacy group both in education and outreach to develop palliative care programs around the country. The National Hospice and Palliative Care Organization also is well established and can be another great source for resources. The Palliative Care Organization, getpalliativecare.org, has particular focus on educating families and patients, and that too might be a great resource for you to begin with. And then the National Academy of Hospice and Palliative Medicine, as well as your state organization. This is the one for New York State, Hospice and Palliative Care Association of New York State, usually has a listing of palliative care programs within each individual state for your reference. Again, I'm going to finish now and perhaps open it up to Rachel to ask additional questions given our presentation.
Thank you both so much for outstanding presentations to help inform our patients and caregivers. I'd also like to take a moment just to mention National Brain Tumor Society's commitment to working with external stakeholders to make sure quality of life care is at the forefront of treating pediatric patients with brain tumors. NBTS supports the Palliative Care and Hospice Education and Training Act, or PCHETA. This legislation would increase federal research funding for palliative care, including pain and symptom management, and would establish palliative care education and training programs for doctors, nurses, and other health professionals. This legislation would also provide for information dissemination to educate patients and providers about the availability and benefits of palliative care. At the end of this presentation, there will be some information for you to learn a bit more about PCHETA. NBTS also recently received a Patient-Centered Outcomes Research Institute, or PCORI, award to develop a patient-centered quality of life research agenda. The goals of our work will be to advance quality of life research for people facing brain tumors, to convene and engage key stakeholders around priority quality of life issues, and to improve patient-centered research and clinical practice as it pertains to brain tumor quality of life. Dr. Porter and Dr. Weintraub, prior to this, we've gathered some key questions that would help our audience further understand quality of life care for pediatric brain tumor patients and families, and how it specifically relates to them. I know that in your presentation, some of these questions were definitely touched upon, but I was hoping perhaps we could pull that information out for our community. The first question is, how should patients with brain tumors, their caregivers, make sure that quality of life care is part of their child's treatment plan?
So I think one way to answer that question is to highlight that most pediatric cancer centers have the key players in place. For example, there's specialists there to address the medical issues. There are social workers and psychologists on staff to address some of the psychosocial issues that come up for these patients. But I think Dr. Porter mentioned it's always a good idea to have a parent or caregiver ask for a palliative care consult, or for to make sure that the provider knows that that this caregiver wants quality of life to be a priority in the management of their child. The parent is often the child's best advocate. And so sometimes providers need a reminder from them that quality of life is in fact a priority.
And I would echo some of what Lauren says. I think a parent requesting a palliative care consult should be an automatic trigger to receive one. However, I think there are still some medical providers that are resistant to that idea. And I think it will require some, determination on the part of the parent to get past those barriers. And this is, again, I stated the concern that we're still educating providers about the difference between palliative care and hospice. And so many times they misunderstand what a parent is asking for. and Dr. Weintraub often refers to it as quality of life, is synonymous with what palliative care can offer, but not every provider understands that. And so I think encouraging parents to just stick with their plan and don't be afraid to be persistent in their quest to at least meet with a palliative care provider. And again, it might not be the physician lead, it might be the nurse, it might be a social worker, it might be the chaplain. All of those resources are typically available within most of the children's hospitals and the pediatric cancer centers where these children are served.
I just want to say it's such an important reminder that when you say that a patient's best advocate could be their caregiver or their parent, I think that's such an important question or important point to make. Another question that I find, this presentation, one of the things that we're really trying to highlight is that palliative care is also about the whole family. And so I wondered if I could ask the question, are there resources to improve that quality of life for family members that are affected by a child's brain tumor diagnosis?
Yeah, so great question, Rachel. At our institution, our child life specialists work with the siblings. Our social workers are available to provide counseling to both the patient, the siblings, and the parents. We're also affiliated with a number of local and national organizations that provide resources to the other members of the family. And certainly I've seen Dr. Porter's palliative care team really hone in on the needs of family members. So perhaps she can talk more about that.
Yeah, so there's no question that when you think about a child's world, it includes not just their nuclear family. Sometimes it's grandma's, sometimes it's the school team. And so definitely over the many years we've been building our program, we really try and identify for the families, who are the important stakeholders, who's been affected by this child's medical illness, and what can we do to make sure that they're not forgotten. So absolutely, that's why our team is so broad. So we pull in child life therapists, and we pull in perhaps the social workers from the Melodies Center, as well as the social worker from the palliative care team, and they all work in concert to try and help think about who needs what at what phase of treatment. Dr. Weintraub brought up survivorship, and the symptoms for some of these patients continue to linger long after we're done the acute phase of treatment. And sometimes that creates frustrations and even a level of PTSD for the patients and the families. They thought they were all done. And yet, again, the symptoms, or some of the symptoms, different symptoms, are still present. So we try, we, again, as a team, collaborate and try and use all of the resources that we have at our disposal at the medical center, and even take it outside of the medical center, as I alluded to the school teams who are going to have to pick up the ball, and perhaps the church community or the sports teams. They are all part of that child's circle, and it's so important to remember them too.
That's such a great point. One, how big the circle is. And the second piece that you also mentioned is, again, you mentioned survivorship and how important palliative care is throughout a brain tumor experience. And again, it's just reiterating, re-highlighting that message and trying to bring that home. That's such a great point. I think, one of the questions that we often ask in Informed in 30s when we're dealing with, these different types of parts of treatment, et cetera, we always talk about costs. And in terms of, asking for a palliative care consult, including that in treatment, is that something that usually insurance will pick up? Is that usually covered?
It is. So one of the really great things that's come out of the last 20 years of outreach and education and raising awareness has been that the insurance companies are getting on board. And so they actually do pay for consults, and they do pay for me to do home visits, and they do pay for our team to be involved. Clearly, the billing for things on the palliative care team is primarily physician directed, right? So they don't pay for the social worker to do the social work intervention. They would pay for mental health counseling. That after COVID has really exploded in terms of everyone's recognition of how important it is. So that's been the case for our mental health counselor at the Melodies Center, where we found that he was very successful being able to generate billing with insurance completely accepting the need for that type of medical intervention. So insurance does pay for palliative care. And in fact, they embrace it. So it's something that is no longer a challenge to try and generate the types of income to help underwrite the cost of the treatment.
Yeah, and I would add that typically when you're talking about this quote unquote supportive care, it's not supportive care. It's care that is medically indicated for these children. And so when it's presented that way, I have not had any issues getting things covered by insurance companies.
Thank you. That's really very helpful. And I know always a question that's on the mind of caregivers when they're looking at this kind of care. Thank you. Dr. Porter and Dr. Weintraub, thank you so very much for joining us today. We appreciate you creating meaningful content for our community and answering key questions to help them better understand the importance and impact of quality of life care for pediatric patients with brain tumors and their families.
It's been a true pleasure, Rachel, not just to see you again, but to share this dialogue with you and the listeners. This clearly gets to the heart of this project that Lauren and I have been working on for a long time. And it now is, my principal career move at building the palliative care services at the Children's Hospital. So we were delighted to be a part of this conversation, and thank you for bringing it to the foreground and narrating the different aspects of the conversation. Thanks.
Yeah, thank you, Rachel. I really appreciate that you and NBTS are focusing on this really important aspect of pediatric brain tumor care. Thanks again for having us.
I also want to thank our community for watching this installation of Informed in 30, Managing Quality of Life Care in Pediatric Brain Tumors. We hope you will join us for our next segment coming out in November about understanding clinical trials. Thank you so much for joining us.